Okay, thank you everyone. Thank you to Neuro Challenge. Thank you to our sponsors for making this possible. How many know a little bit about Parkinson's disease? How many know a lot about Parkinson's disease? How many are expert in Parkinson's disease? I got some ringers down here, they won't admit it though. Okay, here we go. Okay, so it's de rigueur these days to say that I do work with a number of pharmaceutical companies. The only medication I'll mention today that is approved is Sinemet or Carbidopa, Levodopa IR. All the others that I'll mention are in development or experimental. Okay, the characteristic features of Parkinson's disease that are most obvious are loss of dopamine neurons. Here they are here. Represented by this red arrow. These neurons leave dopamine to allow us to move normally. And when you lose enough of these dopamine neurons, they cause the signs and symptoms of Parkinson's disease. And the other characteristic finding is this. These are Lewy bodies in remaining dopamine neurons. And you can see that there's a pale halo and then a dense core. And these findings have been known for many, many years. And I think probably Dr. Elmer went over these features of Parkinson's disease: slow and small movement, stiffness, and tremor. In addition, Parkinson's disease tends to start on one side and is worse on that side. And we expect a good response when the physician gives you dopamine medication. So that's the basics. That's what they taught me in medical school. These days, we also have DAT scan or dopamine transporter scan to help us with diagnosis when it's uncertain. We can give a ligand that binds to dopamine neurons, and this is the distribution. It forms two comets. Here's a head and a tail, a head and a tail. That's normal. Here's a person who's lost dopamine neurons. People lose dopamine neurons from the back forward. So this is consistent with Parkinson's disease. This person has lost both their tails, and this person's lost a lot of dopamine neurons. So we do have a scan these days to help us. If the clinical diagnosis is obvious, we don't need to get this, but when it's not obvious, it can be useful. In addition, I don't think yet you've heard today the fact that in the last 10 years or so, we've come to recognize a lot of non-motor features: loss of sense of smell, constipation, fatigue, sleepiness. Previous speaker mentioned REM behavior disorder, depression, anxiety, and cognitive problems or dementia. So that's Parkinson's disease in 2.5 minutes. How are we going to cure it? Well, here's the story of how we're going to cure it. And the story begins in 1986 with Dr. Larry Golby in New Jersey. And Dr. Golby sees a patient, and he's examining him, and he's taking the history. And Dr. Golby asked, does anybody else in the family have Parkinson's disease? And he says, you know what? As a matter of fact, my brother has Parkinson's disease. And Dr. Golby says, that's kind of interesting. It's unusual for Parkinson's disease to run in a family. And he says, does anybody else in your family have Parkinson's disease? And the patient says, well, as a matter of fact, I have an uncle who has Parkinson's disease. And Dr. Golby says, that's unusual too. Anybody else in the family have Parkinson's disease? And he says, you know, Doc, I've heard stories from family members that actually Parkinson's disease runs in my family. And Dr. Golby said the key question, well, where's your family come from? And he said, the Contorsi region of Italy. And Dr. Golby didn't just leave it at that. He took this very seriously, and he actually contacted colleagues, medical colleagues, physicians in that area of Italy, and he set up a program to try and find members of this patient's family in Contorsi, Italy. And through work over the next several years, they were able to map that patient's family all the way back to the 1700s. So this then is the Contorsi kindred, or that patient's family, all through 11 generations. They found 600 individuals in this family, and they found that 60 of them had Parkinson's disease. So this is a very large and unusual family that has a lot of Parkinson's disease in it. So it's very clear that this family has a genetic cause of Parkinson's disease. Keep in mind, though, that this is very unusual. So what Dr. Golby did, along with his other investigators, is they collected blood samples and they sent them off to the NIH, and the NIH, over a couple of years, was able to isolate the gene, and they found that it mapped to a mutation in, everybody say it with me, alpha-synuclein. And we didn't know what alpha-synuclein does. We still don't really know what it does. I'll tell you one thing that I just found out recently that I didn't realize. Where does the name synuclein come from? Well, it's a protein that exists in the synapse, which are the gaps between neurons, and also in the nucleus of neurons. That's why it's called synuclein. But that had been a protein that was known for a long time, but here, now Dr. Golby and colleagues realized that that family from Italy, they had a mutation in the gene for alpha-synuclein that was causing Parkinson's disease in that family. So think about this. You just discovered that. What would your next step be? What would you do next? Well, I know what I would do next. I would take all the people I have with Parkinson's disease not in that family and test them for that gene. Aha, I found the cause of Parkinson's disease. It's that gene mutation, right? No. People said, no, you're correct. Nobody else had that gene mutation. Drat. That's not good. But some smart people said, wait a minute. Remember these Lewy bodies? Remember that dense core? We don't know what's in there. And so an investigator whose name is Maria Spillattini, she created a stain for the protein synuclein, and she said, I'm going to take some Parkinson's disease brain slices and use my stain for alpha-synuclein and see if in the Lewy bodies that stuff is, in fact, alpha-synuclein. And here's a Lewy body, and when she used her stain, it stained, and in fact, almost all the stuff in those Lewy bodies is alpha-synuclein. Wow, what does that mean? That means all these people who have Parkinson's disease, even though they don't have the same mutation that that family from Italy has, there's something gone wrong with alpha-synuclein. It's clumping up and forming Lewy bodies. So that was the big beginning that said alpha-synuclein clumping is at the heart of Parkinson's disease. And then a pathologist named Brock said, well, this is interesting. Let me try and figure out how alpha-synuclein pathology builds up in the brain. So he took all his Parkinson brains in his lab from people who had passed on and said, let me use that stain that Spillattini developed and take my brains, stain them for alpha-synuclein, and set them up in order from the least to the most, and see what it looks like as far as how the progression goes. And what he saw was it looked like when there was only a little bit of synuclein deposited in the brain, it started down here at the bottom, and it started also in the olfactory nerve or the smell nerve. And as he looked at brains with more and more synuclein clumping, what he saw was that it began to go up and evolve more and more of the bottom of the brain stem, then the area where the dopamine neurons lived, and then ultimately came up and over the top of the brain. Now this last part made a lot of sense because the top of the brain involves thinking and memory. And we know that thinking and memory problems are a late problem in Parkinson's disease, so it makes sense that that part of the brain would be affected late. Now, the next big step we sort of stumbled into. We at the University of South Florida were interested in the idea of could we take fetal dopamine neurons and implant them in Parkinson's disease patients, and would they perform the function of the missing or degenerated dopamine neurons? 2 of our patients died about 14, 15 years after transplantation, By the way, we were never able really to prove that it was a good therapy. It did look like these transplants survived, but we were never able to prove that it really helped. Nonetheless, 2 patients passed on 14, 15 years after transplant, and what did we see? Well, in the graphs, now these are fetal dopamine neurons, neurons that are 14, 15 years old. What we saw in those neurons, clumps of alpha-synuclein that look like Lewy bodies. So what did that mean? That means that the Parkinson's problem, the Parkinson's pathology, moved from the patient's brain into these very young 14, 15-year-old neurons. The disease moved from the Parkinson brain into healthy neurons. The disease moves across neurons. And this was a very exciting finding, and it was pretty obvious to many investigators what this meant, because there was a disease process that was known that was called a prion-like process, because there were a few rare diseases that work like this, how proteins move through the brain and cause a problem. And it kind of works like this. If you have a protein that's normally something like this, it can misfold. It can take on a new shape that's prone to clumping up, illustrated here in this N-like formation. And you can imagine in this N formation, it's easy to stack up or clump up. So that's the aggregation or clumping. And then there's a very important second part. Once it's in that clumped formation, it makes it very easy, if it encounters another like it, to cause it to misfold like itself and then join the clump. So that's called seeding or templating. So here's another normal protein of the same kind. If it comes in contact, it takes on that shape and joins the clumping process. So you can see how that would be a cascading process or a propagating process that we call a prion-like process. And here's another illustration, how it might happen in the cell. Here's the protein, the way it might regularly look. It might take on this misfolded shape and start clumping up, and then you get these larger clumps. But these small clumps can move from cell to cell to cause this process to move through the brain the way that Brock saw it and demonstrated that occurred. And now more recently, using electron microscopy, people have demonstrated, here's what alpha-synuclein normally looks like, but when it misfolds and starts clumping up, here's one way that they can clump up into a sheet, and here's another way that they can clump up into a 5-unit unit, sort of with a hole forming in the middle. And it's not really clear what the most toxic clump is, and people are working on trying to define that. Nonetheless, it's clear that this clumping issue appears to be at the heart of Parkinson's disease. Well, how do we know that this is really the case? Well, here's an interesting experiment that was performed. These investigators took actual Lewy bodies from Parkinson's disease patients' brains that had passed on, and they put them in mice or monkeys' brains, and what they saw was from that Lewy body, they could see progressive expansion of the area of involvement of Lewy body clumping, now involving the mouse or monkey's brain and causing loss of dopamine neurons. So it looked like just putting in a little bit of Lewy body material from a Parkinson brain caused progressive pathology of Parkinson's and clinical features of Parkinson's in the mouse or monkey's brain. So from all of this, this is my simplistic notion. What is Parkinson's? Well, it's synuclein gone wild. Said a little more elegantly, it's synuclein clumping and propagation or spreading of clumping through the brain. And why would that occur? Well, some people may have synuclein that's too sticky. Probably that family from Italy, due to its mutation in synuclein, that mutation probably made synuclein that's more sticky or more likely to clump than usual. Some people have too much synuclein. I didn't mention it yet, but some people have more than the normal 2 copies of the synuclein gene. Some people have 4 copies. Some people have 3 copies. And those people are more likely to get Parkinson's disease. Some people have a decreased ability to clear synuclein. Probably all of us have a little bit of clumping of synuclein going on all the time, but our brains are capable of clearing out those abnormal clumps. But if a person has decreased ability to clear out those little clumps, that might set up this process that can then sweep through the brain. And even though this is the process that's at the heart of Parkinson's disease, we still have to ask, well, what are the triggers that set up this process in the beginning, that set up this cascade that can overwhelm people? And I'll mention one hypothesis a few slides from now. Now, even as that was going on, clinicians were asking, okay, if Brock is right, and this pathology starts at the bottom of the brain and in the smell nerve, and then makes its way up the brain, what should we be seeing as physicians who see patients? And one of the answers is decreased sense of smell. I had seen patients for 20 years. I didn't think to ask what's happening to your sense of smell. And if a patient had told me their sense of smell was down, I probably would have shrugged it off. But now we know, in part because we looked for it due to what Brock found on the brains, decreased sense of smell is very common, not only in Parkinson's disease, but in the years before people get slowness, stiffness, tremor. And often it occurs 5, 10, 15 years before slowness, stiffness, tremor. So it may be one of the first signs of Parkinson's disease. You heard in the previous talk, REM sleep behavior disorder, hitting and kicking at night during dreaming. Again, this often happens or begins 5, 10, 15, 20 years before people get slowness, stiffness, tremor. Again, can be one of the first signs of Parkinson's disease associated with synuclein accumulation down at the bottom of the brain before it gets up to those dopamine neurons. Now, I didn't tell you yet, but synuclein clumping also takes place in nerves outside the brain, including nerves to the heart and the gut. This is just a picture of synuclein clumping up in nerves to the gut. And if you look at people in midlife and ask them about how often they have bowel movements, people who have less than one bowel movement a day in midlife are at higher risk for Parkinson's disease. So constipation is a risk for later onset of Parkinson's disease, i.e. slowness, stiffness, tremor. Is that a risk factor, or is that one of the earliest signs of Parkinson's disease? So we have this notion then that there may be premotor Parkinson's disease, sometimes called prodromal Parkinson's disease. There may be Parkinson's disease cooking in the brain and the nerves well before, years before it gets to the point where it causes slowness, stiffness, tremor. And it may include decreased sense of smell, the REM behavior disorder, hitting and kicking in sleep during dreaming, and there may also be subtle changes on EKG. There may also be constipation. There may also be sleepiness, which I haven't talked about today. So the whole notion here is, can we identify people who have this alpha-synuclein accumulation, i.e. Parkinson's disease, in their nervous system years before they get slowness, stiffness, tremor, and hopefully one day then apply a treatment to slow or stop the process so that they never get slowness, stiffness, tremor, thinking problems, balance problems, etc. And this might include a smell test. Maybe when you're 50 and you go into your doctor, the doctor does a sophisticated smell test to see if your ability to smell is decreased. There may be ways to get some hint about Parkinson's on an EKG. Maybe if your smell is down, you should get that DAT scan, dopamine brain scan that I mentioned. And maybe we can confirm some of this on a skin biopsy because you can see some of these nerves on a skin biopsy. Okay. So what's the cause of PD? I mentioned at the heart is this alpha-synuclein clumping, but what's the cause? Well, one possible cause is genetics, and I've already mentioned that genetic causes are rare. We know about 20 different genetic causes, but all told, if we add them all up, they only account for about 10% of all Parkinson's disease, and each one only accounts for about 1% or less of Parkinson's disease patients. The only exception is in Jewish individuals where there are 2 gene mutation types that we know that account for about 15% each. So we're not currently routinely doing genetic testing. The other possibility is perhaps there's something in the environment that might be a trigger. And how do things in the environment get into our system? Well, there are a couple obvious spots. One might be the nose. Interesting, since alpha-synuclein accumulation might begin in the olfactory nerve. The other place environmental triggers might get in is through the mouth and into the gut. So there's been a lot of interest in the gut. This is one interesting study where investigators took little clumps of alpha-synuclein and put them in mouse gut. They put them into the gut, and they could actually watch the propagation or the spreading of alpha-synuclein clumping work its way up the main nerve from the gut to the brain, get up to the brain and start spreading and cause motor problems in the mouse. So they proved, at least in the mouse, that it's possible that this clumping could start in the gut and make its way all the way up to the brain and cause movement problems. And here some of our colleagues, some of our friends looked at children who were prone to viral infections in the gut. And what they saw was when the children had viral infections, they saw increase in the gut in alpha-synuclein. And their hypothesis was that inflammation in the gut caused an increase in alpha-synuclein, and that might be the trigger to start this clumping process that could then make its way to the brain. That's highly speculative, but there's a lot of interest in whether gut problems, including inflammation or viruses or other infections, might start this whole process. Okay, I'm going to turn now to treatment. I think Dr. Elmer talked to you about some of the issues here. When I see a patient and make a diagnosis, I say good news is medications we have today provide pretty good benefit, 5 to 7 years. Between 5 and 10 years, many patients, especially young patients, find that the standard medication, Carbidopa, Levodopa, immediate release, also known as Sinemet, starts lasting a shorter time, such that patients take it, it works for a couple hours, then wears off. Young patients are also prone to develop dyskinesia, twisting, turning. But the real problem we face, 10 to 15 years out, many patients develop balance difficulties and cognitive problems. All right. So one of the areas of research is how do we develop medications that smooth the motor response through the day? Here's one of the ones. Again, this is not an approved medication. It's in clinical trial. This is called the Accordion Pill. And the Accordion Pill consists of these film layers, and on each film layer is Carbidopa or Levodopa. And then once you have these film layers set out, it's folded like an accordion and put in a tablet, as you see here. And so the patient ingests the tablet, it goes down into the stomach, the capsule dissolves, and then the film sits in the stomach for 10 to 12 hours, and the Carbidopa and Levodopa can then go down into the small intestine where the Levodopa is absorbed. And so the hope is that this might provide nice, smooth Levodopa levels lasting 6, 8, or 10 hours. It's hoped that this might be a nice, long-acting Levodopa, maybe such that patients only need to take it 2 or 3 times per day. So that's in clinical trials right now, and we'll see what the results show. Next is a subcutaneous Carbidopa-Levodopa infusion, and mostly right now it looks like this. There's a pump with 2 syringes connected to 2 small connector wires, and then there's a little needle that goes under the skin, and these pumps push liquid Carbidopa-Levodopa under the skin. And so the hope is that by infusing Carbidopa-Levodopa, you'll get nice, smooth levels of Levodopa. And in fact, if you look at patients who have fluctuations, if you just look at oral Levodopa, you can see the concentrations are all over the place. If you add the infusion, you sort of take away these troughs and smooth things out. In addition, if you just apply the infusion, you get these nice, smooth, maintained Levodopa levels. And this company just reported results. This is a 28-day study, open label, so everybody knew they got the real thing. But they had a reduction in off time from about 6 hours, a reduction of about 3 hours. So that looks good. But I wanted to show you one of the main issues is that where you insert the needles and do the infusion, 58% of patients got nodules. These are hard little bumps under the skin. They do go away over weeks to months, but they can be a nuisance. And then the other thing is 21% got bruising, and the bruising can be kind of painful. So we're waiting to see how do patients react to this. Is it tolerable? Is it not tolerable? Can either the medication or the injection with the pump be altered to make this easier for patients to tolerate? We'll have to see. So those are two sort of ways to smooth the response. An alternative is to try and find treatments to treat the off period. When the medication wears off, is there a way to quickly improve the benefit? So here's one option. This is currently in front of FDA to evaluate. This is inhaled levodopa. This doesn't have carbidopa in it, so it's only for patients on oral carbidopa levodopa. When a person wears off, they can inhale this, and the hope is that it improves the patient's status over several minutes and provides benefit maybe 60, 90 minutes. And so far, clinical trials have been positive, and as I said, that's in front of the FDA. An alternative is this film strip that contains apomorphine. It's the same idea. You put it under the tongue, it dissolves right through the lining of the mouth, gets into the bloodstream and goes up to the brain. Again, hope is that it works pretty quickly and provides benefit. It's finishing up clinical trials with the aim of getting to FDA soon. All right. Now I'm going to head back to the alpha-synuclein story, because what we really want to do is we really want to find patients way early in disease, one day even before they have slowness, stiffness, tremor, and find a way to slow or stop disease progression. And especially we want to keep people from getting to the point where they have balance problems and thinking and memory problems, because that's what's really hard to treat. So what are anti-synuclein therapies? Well, I showed you this slide before, but we're thinking a lot about how do we look at this synuclein and keep it from clumping up? What are the ways we can do that? Or can we keep the synuclein from moving from cell to cell? And right now there's a lot of interest in anti-synuclein antibodies. Here's a depiction of an antibody. It looks like a big Y, and right at the tip it's very specifically built to target what we call an antigen. It very specifically locks onto a target and neutralizes it. Another way to get this sort of thing, or to create antibodies, is through a vaccine. When you get a vaccine like the flu vaccine, you're getting a dead virus particle, so your body makes the antibodies rather than you receiving the antibody itself. So here's how this works. Here's a neuron. It's got synuclein in it. It's going to try to send synuclein to a nearby neuron. And here you see synuclein starting to build up. It builds up, it gets into this clump, and now that clump is big enough to be toxic. Well, the idea is if we give this patient an antibody, it starts to build up, but look, here comes this antibody. It creates a physical obstruction to the clump growing bigger. And so here, it can't get any bigger. It's of the right size for the body to clear it out, and we've prevented toxicity. So that's the whole notion. And in animal models, it works very well. Here's one study. This is the Roche antibody, and they were able to prove that when you give it, it lowers synuclein in blood. That's not the same as lowering it in brain or showing that we help people, but this was the first study, and it showed that you can lower synuclein in blood. Here is a vaccine. This comes from Aphoris, and they showed that 50% of vaccinated patients developed alpha-synuclein antibodies. So where are we now? Currently, there are 2 studies looking at antibodies to alpha-synuclein. One is from Roche, one is from Biogen, and they're enrolling new or recently diagnosed Parkinson patients, not on symptomatic Parkinson patients, and these are patients who won't need symptom treatments for 6 to 12 months. And I want to show you how this works. So how do we get to a cure, I wrote here. And this is all about clinical trials now. So normally a patient gets the onset of motor symptoms, slowness, stiffness, tremor. If there were no symptom treatments, the patient would just progress and get worse and worse. If they didn't go on any symptom treatment for a while, they would get worse and worse and worse. But there would come a time when the patient would say, hey doc, I'm really getting slow and stiff, I got too much tremor, I need symptomatic therapy. So here the person goes on symptomatic therapy, they improve, they get pretty close to normal, but not completely normal. And then how they do after they start symptomatic therapy really depends on how much symptomatic therapy I give them. But notice that in here, how they're doing really depends on how the disease is doing. And so in these clinical trials, we're trying to take advantage of that very fact. So if a person is diagnosed pretty early so that their symptoms are quite mild, we have the opportunity to enroll them in a clinical trial. In that trial, they can get the antibody medication that can be the real stuff or the fake medicine we call fakes, placebos. And we can see, does the real stuff slow progression of disease, meaning slow progression of slowness, stiffness, tremor, compared to placebo. And so this is the opportunity to evaluate potential disease-slowing medications. Unfortunately, if they see a doctor and they make a diagnosis early and symptomatic medication is just started then and there, even if the patient doesn't need it, well, we lose our opportunity to evaluate these exciting medications. Similarly, we see a lot of patients who wait until they say, hey, doc, you know, it's been a year since this slowness, stiffness, tremor started, and now I'm at the point where I want symptomatic medication. So we start it, but we've missed our opportunity to evaluate medications. And so this is a really important part of what's going on in Parkinson's disease right now. We've got companies coming to me saying, how do we evaluate these new exciting therapies we have? And I explain, this is the part of disease where we can really look at, are we able to slow progression of disease? And they say, geez, are there enough patients with early disease entering clinical trials that we can do this? And so we really got to get in the mindset of, if you hear anybody who's newly diagnosed, you got to tell them about these clinical trials. And we got to get doctors around the country, rather than just throwing a little bit of Cinnamon at the patient, to think about these studies if we're going to get to the point where we have a cure or to slow disease. So I wrote, to determine whether these exciting new therapies can slow disease progressions, patients must join these studies soon after diagnosis and before starting symptomatic therapy. And then we have this cartoon. My specialty is referring patients to the right specialist. So again, we want docs to refer patients to these studies. Otherwise, companies won't be able to test these medications. All right. So I did bring just a couple others for your interest. This is nilotinib. Now, nilotinib got a lot of PR. It's a little more complicated, but nilotinib is about the fact that in Parkinson's disease, I mentioned a lot of people have difficulty clearing out these little clumps of alpha-synuclein. And just to throw out the name of it, c-Abl is part of your ability to, or interferes with your ability to clear out these clumps. So c-Abl is increased in Parkinson's disease, and nilotinib decreases, or nilotinib inhibits c-Abl. So nilotinib helps you clear out some of these aggregates of alpha-synuclein. And in studies in animals, nilotinib can reduce these alpha-synuclein aggregates and improve outcomes in animal models. So Georgetown did a very small study. It was open label, which means everybody knew that the patients were getting the real stuff. There was no placebo control. And they did it in Parkinson's disease patients with dementia, in Parkinson's disease patients and patients with dementia with Lewy bodies. So a very unusual small study. And what they saw or reported was that patients' motor benefit was mild to moderate, but their thinking and memory score improved very dramatically. And in addition, there were videos that were released on the web where patients improved dramatically. So everybody got very excited. But you have to remember, this is a very small study, just a few patients, and there's no placebo control. So you have to take this with a grain of salt. Nonetheless, it does look good in animal studies, and that study suggested that it's pretty safe, or reasonably safe. So it's moving on to clinical trials. And there are actually two trials going on, one supported by Michael J. Fox, the other is being run at Georgetown. In the one we're doing with Michael J. Fox, there's part one. This is for Parkinson patients who are on levodopa and diagnosed more than 5 years ago. So this is a little bit different than early. So that's the first part. And then the second part will go to patients with early diagnosis. I'm going to mention one other therapy that's being evaluated to potentially slow disease. These investigators, led by James Surmar, looked at rejuvenation of neurons in Parkinson's disease. And what he said was, geez, if we look at juvenile, young dopamine neurons, they use pacing with a sodium channel. So little sodium comes in, that sends a signal down for the neuron to release dopamine, and everything is good. But as the neuron gets a little older, it replaces these sodium channels with calcium channels. So now a little calcium comes in, that sends the signal down for the neuron to release dopamine. But the problem is calcium interferes with the mitochondria's ability to generate energy. So over time, the energy ability of the neuron is decreased. And when the energy ability of the neuron is decreased, it can't fight toxins and other insults as well. So he said, in order to improve the energy level of these neurons, let's add an inhibitor here so that not as much calcium gets in. So if we add a calcium channel blocker, what happens? Well, he found that you can do that just fine, and these sodium channels are reinvigorated, and now sodium again takes over this pacing mechanism, and the energy status of the dopamine neurons improves. So the name of the calcium channel blocker that's being tested is isradipine. This study's not enrolling right now, but is now about halfway through a 3-year study, so we'll see what the results show as far as its ability to slow progression of Parkinson's disease. So what have I said about the research emphasis? We'd like early, accurate diagnosis. It'd be nice to have a blood test or some other test to confirm a diagnosis of Parkinson's disease. And remember, ultimately, especially when we have something to slow or stop disease, we don't want to wait for slowness, stiffness, tremor. We want to diagnose people years before that occurs so that maybe they'll never even get to slowness, stiffness, tremor. And that may be based on decreased sense of smell, REM behavior disorder, maybe some EKG changes, and we'll see how that happens. Biomarkers, I didn't say a lot about today, but investigators are looking at chemicals in CSF, maybe blood, to help us make the diagnosis, but also be very helpful to track progression of disease in these studies, so maybe we don't have to depend so much on patients who are just diagnosed, and to get a more accurate assessment of disease progression. We still want convenient, well-tolerated medications that provide good benefit for slowness, stiffness, tremor throughout the day. It would be great to have really good medications for thinking and memory problems and balance problems, but I think it's going to be really hard to do that, and that's why I think we have to place so much emphasis on slowing disease progression. And therefore, my last point, we really need medications that will slow or stop disease progression. And I think right now there's just a huge amount of excitement and enthusiasm because we've identified really, I think, the core of the disease, this clumping of alpha-synuclein and the propagation of that problem through the brain, and we're identifying more and more ways to try and stop or slow that process. So hope is running very high, and with that I'm going to say thank you very much.
Thank you, Brent. Good afternoon. I'm Emily Walsh, publisher with the Observer Media Group, and I'm honored to serve as your moderator for today's panel, Understanding Your Parkinson's Medications. We are pleased to have 3 local Parkinson's specialists with us this afternoon, Dr. Ricardo Gonzalez, Dr. Carol Pappas, and Dr. Dean Sutherland. Let's give them a round of applause. Yeah. They will be discussing the following therapies utilized in various aspects of Parkinson's treatment: deep brain stimulation, or DBS, Ritalin, Nuplazid, Gocovri, Xadago, Apokyn, the Nupro patch, and the Duopa pump. Please note that content in this presentation should not be construed as an endorsement. Always consult with your physician about which medications are appropriate for you. The companies that manufacture these therapies are all here with us today, so if you have any questions or would like more information, please visit their tables after the presentation. So let's begin. Dr. Sutherland, we will start with deep brain stimulation and Rittery.
All right, good afternoon. I'm so glad to have you guys here. This is a wonderful, wonderful expo. I mean, we couldn't have imagined 10 years ago it would grow into this, so awesome. So they've asked me to talk for a couple of things. First, we're going to talk about deep brain stimulation. So deep brain stimulation has actually been around for almost 20 years in terms of FDA approval. So it's not brand new. I'm surprised how many times I actually hear people say things, oh, there's a new procedure for Parkinson's deep brain stimulation, or I'll hear somebody in an emergency room say, I can't believe that must be a cardiac pacemaker or something like that. So deep brain stimulation has been around for a long time, and we've got a lot of good data on it that really shows that it works. So let's just talk over this first slide here on it. I'm going to read off of this. So DBS uses a small pacemaker-like device placed under the skin in your chest to send electronic signals to your brain that controls your movement. To give you relief, these signals block some of the brain messages that cause the movement symptoms of Parkinson's. So when you have Parkinson's, your brain, there's two different systems in your brain that allow you to move. One suppresses movement and the other increases movement. And there are two different systems that kind of work in a push-pull mechanism in your brain, so they're balanced if you don't have Parkinson's. When you have Parkinson's, that mechanism becomes unbalanced. And so deep brain stimulation doesn't really program your brain as much as it sort of deprograms your brain. It takes the part that's overactive and then reduces that activity so that the other part, which was now underactive, can kind of become more equalized. And we're not actually sure exactly how it works, but that's kind of the theory at this time. Deep brain stimulation helps control movement symptoms of Parkinson's: tremor or shaking, slow movement, which we also call bradykinesia, and stiffness or rigidity. When medications are not as effective as they used to be and your symptoms make everyday life a challenge, deep brain stimulation may help. So who is a candidate for deep brain stimulation? Most of the time we have patients who've had Parkinson's for 5, 10, 15 years who have been taking medication for that, and the medication works, it relieves their symptoms, but over time it also can cause some side effects. So the main side effect that you can see, such as on people on TV like Michael J. Fox, when they take their medication, is they start to wiggle around. And these wiggling movements, it's not a tremor, it's called dyskinesia. And dyskinesia can be disabling. People can fall down from it. They can knock themselves into walls and doors. It can also interfere with eating, with doing your activities of daily living. It can be kind of stigmatizing when people see you have dyskinesia in public. So dyskinesia is definitely a problem. Now, in between dyskinesic periods, however, as Dr. Hauser pointed out, people can often their medications wear off. And so we're trying to figure out how to improve those with medicines. But deep brain stimulation actually helps with that problem as well. So when you're wearing off and you can't move, deep brain stimulation may be a really good option. So a number of large studies have been done with deep brain stimulation, one here in the US with the Veterans Administration and one in the UK with, I think, about 400 patients in each one of those studies. And it's interesting because they both found the same thing. Patients had about 6 more hours of good on time when their medications were working well when they had DBS. So it absolutely does work, and it works quite well. It does have its own potential side effects. So here's another slide. We're going to talk about some of the side effects here. When we do the deep brain stimulation, we have to put a little hole in your skull and put an electrode in through that hole in the skull, and there's a wire that goes down behind your ear and over your chest to this pacemaker. Because you now have an electrode in your brain, there is a risk of bleeding into the brain at the time of the surgery, as well as afterwards. So brain bleeding does occur. Probably about 1% of cases, we think. So pretty unlikely, but it is a risk. Stroke has been reported in some patients that have had deep brain stimulation. I have one patient out of probably 200 that I've seen with DBS who had a stroke elsewhere came to see us. So that's very rare also. Leakage of your cerebrospinal fluid from your brain, that can happen as well. Pneumocephalus is where you get a little bit of air in your brain or your skull. So that is something that just happens with brain surgery, unfortunately, for some people. It's usually not dangerous, usually resolves itself. And seizures have been reported as well from deep brain stimulation surgery. So it's got its own problems. So if you're concerned about this or you want to hear what the other potential side effects are, if you go to medtronic.com, they have a whole list of these things that have been seen and reported. Now that being said, how do people do with deep brain stimulation? Well, they've done these satisfaction surveys, and what we see is that about 85% of people who've had deep brain stimulation for Parkinson's are very satisfied with it, 85%. 10% of people are mildly or moderately satisfied with it, and 5% of people are unsatisfied with the results. So we know that it works for most people quite well. There's a few people it doesn't work as well for, and that can be very frustrating. I mean, imagine you go through brain surgery and it doesn't work as well as you thought, but that's a minority of people, actually. I think right now in my practice I have 60 or 70 patients with deep brain stimulation, and most of them are doing quite well. It does require some interaction with your doctor. If you have deep brain stimulation, you have to go back and see your doctor every 3 to 6 months. You might have to have it programmed extensively at the very beginning. You can't really just stop your medications, but usually we can reduce the medications by 25 to 50% with DBS. So that actually is a very good option for people who are having dyskinesias and off periods. And there's a few cases where people cannot take the medications, but it clearly helps their tremor. I have patients who will take Sinemet or other medications, and their tremor goes away, but they become violently ill or nauseated, and you put them on 5 different medications, and the same thing happens. For some of those patients, we have sent them for deep brain stimulation because they can't tolerate the medicine at all, even from the very beginning, and it works very well for that as well. So in certain instances, we do that. Okay, now we're going to talk a little bit about Rytary. It's not Rittery. It's Rytary. It's made by Impact Pharmaceuticals. So Dr. Hauser covered this a little bit too, with the extended release formulations of Levodopa and things that we're working on. So Rytary is actually a medication that's been out for a couple of years now. So Carbidopa and Levodopa are what's in Sinemet. And it's called Sinemet because a French gentleman figured out if you just give people Levodopa, they tend to get nauseated and will vomit. But if you add Carbidopa, it reduces the nausea. And in French, Sinemet means no vomiting. That is true. That's a true story. So when you take Sinemet, though, it lasts about between 2 to 6 hours in your body. It really, the half-life is generally about 3 or 4 hours. So it generally wears off quite quickly. So as time goes by with Parkinson's, people start taking the medications closer and closer together. So what Rytary does is it lasts an extra hour or two beyond what regular Sinemet lasts. There was a drug that was called Sinemet CR. Some patients take that successfully. Sinemet controlled release. In my experience, it doesn't really work as well as it should, but Rytary does. So I've been very pleased with that. I've probably put about 400 people on Rytary over the last couple of years with pretty good success. Again, not for everyone. Some people have side effects from it. The side effects you can get from Rytary are nausea, dizziness, headaches, sleep problems, crazy wild dreams, dry mouth, dyskinesia, which is the writhing movements we were talking about, anxiety, increased constipation, vomiting, and low blood pressure, which is also called orthostatic hypotension. Those are the same side effects that you get with regular Sinemet because this is essentially the same drugs. It's Carbidopa and Levodopa just in a package that allows it to be released very slowly into your body. And if you want to find out more about Rytary, you can go to rytary.com, and they have lots of information on there about prescribing it and how it's taken. And there's even some help for medication assistance in terms of financial help, or you can talk to one of the reps back here about that as well. And so I do think it's a very good option if you're having a wearing off and dyskinesias, because we can work on both of those aspects with this drug. So a lot of people who have advanced Parkinson's will actually use a combination of deep brain stimulation and Sinemet or Rytary or things like that. So it doesn't mean just because you have one, you can't be using the other. Okay, so I'm going to wrap it up, and next speaker.
Thank you, Dr. Sutherland. I knew I would mess up one of those pronunciations of these drugs. Next, we'll have Dr. Pappas tell us about Nuplazid.
Okay. I do want to thank the organizers for including me in this august group. And you people are wonderful coming out on a beautiful Saturday to hear what we have to say. Nuplazid is, do you have the next thing? Oh, this one. Push forward. I'm technologically impaired. Yeah, nope. There you go. Here, I got it. You do it. Okay. Nuplazid is a prescription medication used to treat hallucinations and delusions associated with Parkinson's disease. More than 50% of patients with Parkinson's disease at some point develop either hallucinations or delusions. And I know the previous speaker this morning mentioned that we see that a lot in Lewy body disease, but we also see it in Parkinson's disease. We call it Parkinson's disease psychosis, PDP. Now, a hallucination is something that you see that isn't there. The most common ones are visual, but you can also have olfactory or tactile or auditory. A delusion is something that you think is true in spite of the evidence that it's not. Okay, so many times patients will say that they see things at the side of their vision, that's a hallucination, or I've had patients just sit and look outside the window and refer to, you know, the dog that's up in the tree and telling his wife that's what he sees. That's a hallucination. But thinking that your wife is cheating on you is most likely a delusion, I hope. So there are both internal causes of these things and external causes. Certainly PDP, Parkinson's disease psychosis, is an internal cause, but there's also medical causes that need to be ruled out. Dehydration can cause these. Infection, like a urinary tract infection or a pneumonia, can cause Parkinson's patients to hallucinate. We already said dehydration. And then external causes. Some of the Parkinson's meds, particularly the dopamine agonists, can cause hallucinations. Alcohol, recreational drugs, some dim lighting. So what patients are at risk for hallucinations? Those patients who are older, who have had Parkinson's disease longer, who have more severe Parkinson's symptoms. As was said in an earlier talk, previously all of the meds for hallucinations and delusions that were available made our Parkinson's worse. And that's why you should all say you're allergic to Haldol, because that's used to treat hallucinations, but it makes your Parkinson's disease worse. Nuplazid is the first and only drug on the market that's been approved to treat Parkinson's psychosis because it does not worsen the motor symptoms. It's easy to use, 2 pills every morning. Usually it doesn't kick in right away. It takes anywhere from 4 to 6 weeks to really see a difference, and I believe we saw a slide earlier about the course of improvement. And most importantly, there's no need to adjust your Parkinson's meds. Side effects, as you can see, there's nausea, edema, confusion, hallucinations, and as with any antipsychotic medication, there's the black box warning of a risk of death in older, sicker patients with any of these medications. I think I'll stop there.
Thank you, Dr. Pappas. Now we'll have Dr. Gonzalez tell us about his thoughts on Gocovri and Xadago.
Hello, everybody. I'm very excited to see everybody, all my patients here. First of all, thank you for being in Paradise and having us here. This is a dream. 20 years ago, I came here to this Gulf of Mexico, and now here, living my dream, working with my patients and Parkinson's. Isn't that the name of this medication sounds a little suspicious because it's Gon, Corey, so Ricardo Gonzalez, and the initial of my wife, B. So it's another medication we have now. It's an extended release amantadine, and in the end, when there is some complications with especially dyskinesias, we are trying to improve this symptom. Amantadine has been used, and going a little bit in the history of amantadine is actually a flu medication that when there's a flu or epidemic of flu, many people not having only the flu but Parkinson's, not only getting better with the flu but the Parkinson's. So we have been using this medication in Parkinson's not only for dyskinesias but as well for energy. But now have this new medication, this new formulation that is a extended release, and we're very happy to have that another tool to help our patients with Parkinson's. We always in Parkinson's try to get the right cocktail of the right medications. Initially, we try to get, in the next slides, we're going to talk about another MAO-B inhibitor, which is the medication that we usually start to try to keep you look good by seeing people doing exercise there. Exercise definitely is the only thing that has been shown to be neuroprotective. So we want to speak in the next slide about the Xadago, which is an MAO inhibitor, which we've seen with other MAO inhibitors like Rejuvenation or Synuclein, and now this one to get a little improvement in the unified Parkinson's disease rating scale. Usually you have to use this medication and give it a chance because most of these people or most of the patients with Parkinson's want to control for the tremors, but tremors and Parkinson's only is the tip of the iceberg. We have to look really how they can improve the cognition, how we can try to modify the speed of the progression in Parkinson's. I always say that Parkinson's, you're driving a car with a broken brakes. So the only way to you have this horse that is you're not able to control, you have to try to slow it down. The most important, as you see, is exercise. We try to, as a physicians, I specialize in movement disorders, we try to give you the right cocktail to improve your outcomes. But the person in charge is you. So you are the person that do exercise. Caregivers are very important for us. But talking to the GONRIC, again, is probably in the end, when you have complications, I try to get you with some dyskinesias. So dyskinesias are two types of dyskinesias. The peak of those dyskinesias, you take too much, you have to do these kind of movements like Michael J. Fox when you have too much. So this medication, the GONRIC, is designed to decrease this kind of dyskinesias. But there is another type. If you are having dyskinesias before the next dose is what we call the wearing off dyskinesias. So we're very fortunate to have now this very sustained, extended release amantadine that we're happy to try and a slow increase in the dose. We go to the next one. Of course, any medication will have side effects. In particular, this one, and it's very well known, amantadine for hallucinations. We already talked, Dr. Papas talked about hallucinations. We can try Nuplazid. In the past, we were using for hallucination or medication, but Dr. Papas talked about this. Unfortunately, this medication can produce dry mouth, swelling, that it can be sometimes associated with Parkinson's by itself as well. Constipation, which we don't know it really is part of the Parkinson's or it's worsening with this medication. And orthostatic hypotension or orthostatic. Sometimes when we see orthostatic hypotension, it could be a red flag for us. Is this a side effect of the medication? Or is this patient having a Parkinson's plus, multisystem atrophy, or what's going on with this? Now, the Xadago is the MAO-B inhibitor, and again, this is a MAO-B inhibitor, and it's in my formula to give medication for Parkinson. I said, are you barman? I want to use a cocktail. So in that cocktail, if you are in the beginning of Parkinson's, I'm going to give you a cherry. It's an MAO-B inhibitor to make you look good. Try to decrease your unified Parkinson's disease rating scale at least in 4 points. But I had to score this in at least 6 weeks. Many people say, but this is not doing any for me because I don't see my tremors is there. What's going on? So usually I do my Unified Parkinson's Disease Rating Scale, and I say, okay, come in 6 weeks and see if it really is working. Your score, this score goes, the higher the score, the worse in Parkinson's, the lower the score, the better. So your score is like 14. I say, I hope you do exercise, you take one of these medications, your score is going to decrease in 4 points in 6 weeks when I see you back. And usually it's the case. So, of course, any of these medications, in this case, the MLB inhibitor, can have problems. And this medication, in particular, Xadago, is not approved, or it doesn't show to be approved as monotherapy. But again, this medication can produce side effects, like we talked before about dyskinesias, and we talk about in dyskinesias, we can try these dyskinesias with amantadine on Corby. Of course, they can be having more falls, but again, we wonder if the falls is coming from the Parkinson's by itself or the medication. Nausea, the nausea as well coming from Cinemed or Carbidopa, Levodopa, or from this medication, or any medication. You take into medication, you produce gastritis in the stomach, and then we have nausea. Trouble sleep and falling, again, the same thing. It's coming from Parkinson's or it's aside from the medication. So, underline, again, you are in charge of your Parkinson's disease. You have to keep moving. Parkinson's disease is not only medications, exercise, speech. You have to get your facial expression. You have to do the exercise, swallowing. You have to bring it to us, your land release, the complaints, and we can help you. But you are in charge of Parkinson's. Thank you so much.
And now we'll have Dr. Pappas give us information about Apokin, the new Pro Patch, and the Duopa pump.
Well, as we've seen, Parkinson's disease affects many systems of the body, multiple body systems, not just the motor symptoms. The most common non-motor symptoms are those that are GI. So all of the 3 medicines that I'm going to talk about skip the GI tract, which is a big advantage.
Make sure you stay in front of the mic.
Stand in front of the mic. Okay. The most common non-motor symptoms are GI, and those are constipation, difficulty swallowing, delayed gastric emptying, and gastroparesis. What this means is, because I really do want you to understand this, when you take a pill, if you have delayed gastric emptying, that pill can just sit in your stomach. It can sit there for 15 minutes. It can sit there for 5 hours. It can never get to the small bowel where it's absorbed. So this is a serious problem. In normal people, the time from mouth to evacuation is 22 hours. In patients with Parkinson's disease, it's 44 hours. That speaks to how much the GI tract is affected in Parkinson's disease. And that's why we see people complaining of constipation and difficulty swallowing and bloating across the board. Okay? Many people go to gastroenterologist after gastroenterologist saying, what's the problem? Well, it's the Parkinson's disease that started really in your stomach and in your olfactory bulbs. So as I said, the next 3 medications have the advantage of skipping that absorption and getting into your system in different ways. The first of these is Apokin. Apokin is used by injection as needed to treat off episodes. In other words, it's not meant to be the basis of your treatment. It's meant to be a rescue medicine. And we saw the video by Dr. Elmer early on with Dr. Dewey injecting a patient with Apokin, and he went from off to on. I remember the first time I saw it, it was on the Today Show, if you can imagine. I can't remember who the MC was back then, but Dr. Olenow injected a patient with Apokin on air, and he went from frozen to walking off the stage at the end of the thing. So Apokin is meant to be a rescue medication. You carry a case with you that has a pre-measured amount of the medication, which is apomorphine. That's a dopamine agonist. And so, example, you're in a restaurant and you feel yourself going off. You might give yourself an injection. It'll kick in 5 to 10 minutes. It'll last about an hour. So get you to your next dose of levodopa. It does not take the place of your other medications. I want to make sure that that's clear. The side effects would be the side effects of any dopamine agonist. Sleepiness, sudden uncontrolled movements like dyskinesia, nausea, vomiting, hallucinations, as we've heard of that class, and some edema. So apocrine's very straightforward, but it's a great drug to have at your mercy, for availability to help you in your daily life. Let's go on to the next one, which is Neuro. And Neuro is a wonderful drug. It is a dopamine agonist that's a patch. And I don't know if you folks, a lot of you have knowledge of Neuro. It's the only Parkinson's patch you wear. And what you do is you put the patch on in the morning and you take it off 24 hours later. It works for 24 hours. Or I have my patients usually put it on at night because it helps them sleep. And then when they wake up in the morning, they're not off. They don't have morning akinesia. So it's a really nice way to use it that way. The actual drug is rotigotine. It mimics the action of dopamine in the brain, and it releases it directly into the bloodstream. Remember that our goal in Parkinson's is to try to replace your dopamine continuously. In the non-Parkinson's brain like mine, thank God, I have dopamine available to me all the time. All the time. In patients with Parkinson's disease, as we've seen initially, you still have some dopamine in your brain, but as the disease goes on, there's none left. And so you totally depend on a pill. So your brain sees peaks and valleys of dopamine. So that's what we're saying with something like the patch. You have continuous stimulation with a dopamine agonist. Okay? It can be used as monotherapy in early disease, and it can be used in conjunction with levodopa in later disease. In the original studies, on time improved about 3 to 4 hours compared to baseline, with a concomitant decrease in off time. The side effect profile, again, is very similar to those of other dopamine agonists. The sudden episodes of sleepiness, and you'll remember that was first described in Mirapex when Mirapex was just an immediate release drug. People were falling asleep while they were driving. That can be a little inconvenient. So that is a potential side effect of Neuro, as are hallucinations, Parkinson's disease, psychosis, orthostatic hypotension, which is that drop in blood pressure, compulsive urges. I've had a patient lose $60,000 gambling. These are real things. These compulsive behaviors have to be identified quickly so that we can intervene. Fluid retention, dyskinesia. One of the problems with Neuro, and really pretty much the main problem that the patients who don't tolerate it complain of, is skin reactions. I've actually had people not be able to use Neuro because of skin reactions. To try to alleviate some of that, you move the patch from day to day, and they give you a nice little body map. One day you might put it on your left shoulder. The next day you might put it on your right shoulder. You can put it on your thigh. You can put it on your back. You can put it on your flank. So that actually in a 2-week period, to try to avoid some of these skin reactions, you don't put it in the same place. Okay? I think that's all I have on Neuro. Okay. Duopa pump. The Duopa pump is a drug you know well. It is Carbidopa levodopa. It is formulated as an intestinal gel, and it's delivered through a pump, through a tube that goes directly into your stomach. And most people hear a tube that goes into your stomach and their brain shuts off. And I would urge you to try to keep an open mind, because this is one of the most revolutionary things I've seen in my practice. So this very same drug, who you know, gets delivered to you continuously for 16 hours a day. So as I was saying earlier, our goal is continuous stimulation. You get levodopa at a smaller per hour dose, 16 hours a day. Okay? It skips the GI tract because the tube goes right into the jejunum where the drug is absorbed. The potential adverse effects, as you can see, I think the main one that I've ever seen is a complication of insertion of the pump. Basically, the daily, you're going to have a talk on Duopa, so I don't want to take all of the speaker's thunder. But what you do is you wake up in the morning, you take the cassette out of the refrigerator, because they send you 30 cassettes a month. You take the cassette out of the refrigerator, let it warm up, hook it up somewhere around 8 o'clock in the morning, and push a start button. That's it. That's all you have to do. And there's harnesses that you can wear to hold the pump. You wear that pump for 16 hours a day. If you feel that you're going off, you have a way to give yourself an extra dose. It's very programmable. I think the most important thing for you to know is that unlike DBS, Duopa is very easily reversible. That tube can come out of there, that's it. So if you don't like it, it can be removed. I will tell you that I don't know of a single patient since it's been put out that has elected to have it removed, because it's changed their lives so. Okay, but that's a key element of it. So device insertion, complications, yes. Nausea, the same effects, side effects that Carbidopa levodopa has, Duopa has, because it's Carbidopa levodopa. Again, it increases on time by about 4 hours a day. It decreases off time by about the same amount. Okay. I find it particularly advantageous in patients who have balance problems and core issues, which becomes such a problem in later disease. Okay. Those patients respond real well to it, but of course it treats all of the other symptoms of Parkinson's as well: tremor, rigidity, bradykinesia. So really nothing, the only thing that's different about Duopa is the way it gets to your system, and it skips that nasty stomach that becomes our enemy as we go on.
So let's just take a few minutes with each of you and on any other final thoughts on understanding these different Parkinson's medications.
Well, one thing I would say, which is probably kind of preaching to the choir here, no pun intended with the choir, but so if you have Parkinson's, you probably should see a doctor such as the three of us who specialize in Parkinson's disease, movement disorders specialists, because as Dr. Papa said, there's an art to this. It's complicated, and we've been doing this for a long time, and we can probably find out things about you that would help us to make a decision as to what to put you on. General neurologists are pretty good, you know, and they usually will be able to be helpful. But I think a movement disorders specialist for Parkinson's is key, especially as Parkinson's progresses. I think it makes more and more sense. You really should see somebody who is as an expert and knows what to do and knows the side effects as much as you can. So that's really the only thing I would add really there.
Actually, I was going to say much the same thing. You know, if your doctor just puts you on Sinemet and keeps upping and upping and upping the Sinemet and doesn't think about any of the other options, that's a sign that I don't want to. I've had so many patients complain to me. I go to this doctor and he just keeps upping my same medications and I don't get any better. And the other thing that was made in one of the talks this morning, a point that's really important, is that a movement disorder specialist does have his or her pulse on what's coming out. And I have to tell you that in my community, general neurologists don't refer people to DBS. They don't refer people for Duopa. They have so much on their plate that they're not super well educated in those things, so they put their bias on the patients when there's so many more things out there that we could offer to you, and you have to be satisfied. You're the customer, and if you're not satisfied, you've got to go somewhere where you can be satisfied, and I think that that's super important.
Sometimes what you treated is no Parkinson's, it could be Parkinsonism. And it's very important you respond to dopamine. So I always give the example to my patient like this. You look at me, they are thinking you are Mexican. I know Mexican and Colombian. So not everything that look like Parkinson's could be Parkinson's. They could be Parkinsonism. And this is very important concept in medication. Because sometimes you can't know the history of having a little tremor, or decrease in swing, or shuffling. You just come with a little, most of the memory problems. You're thinking about Lewy body dementia, or you come a little more wrong with balance. The tremor is not as much. Or you go with tremor in both hands. I wonder if there are some red flags. I would say, okay, let's do it for a dopamine challenge. So I'll give you the standard is dopamine and see, okay, really, you respond that much, and you just come the typical features of Parkinson's, and you respond very well, you're in the true Parkinson's. But I give you you respond a little bit or you don't respond at all, and the medication is only give you side effects. I wonder if you have one of the Parkinsonism. I want to ask you just to walk. Sometimes you have the magnetic gait that would probably have number of pressure hydrocephalus. Or I want to look at really in that first time I give you the dopamine, you respond very well, I give you that amount. But you respond a little bit, I just give you a little bit. And in Parkinson's, I do small steps. Usually I start one medication and trying to be in control, because sometimes we have too many medications, not only mention the medication we're giving to you, but the medication another doctors are giving to you. So that's very important, and again, it's not only medication. If you have Parkinsonism, not be disappointed, there is treatment as well. Exercise, caregivers are very important for us as well, and we don't not be trying to say Parkinson's or Parkinsonism have a lot of treatments. And as a multidisciplinary team, physical therapies, occupational therapies are very important for us. Caregivers are very important for us. And as well, we get into the end of life, caregivers is very important for us. And we have to have time to have a moment and say, okay, what's going or what's next? Thank you so much.
How about a round of applause for our esteemed speakers today? Thank you so much.